In epilepsy care, a lot of patients present with different signs and symptoms that may or may not be related to an epileptic disorder. In our practice particularly, most patients come in from prior neurologists who may have had a short 30-minute routine EEG study done already, or patients may have not been thought of in need to get a routine EEG study. What determines us to order either the routine EEG or the long-term EEG is, one, what is the patient presenting with? What kinds of signs and symptoms does this patient have? Two, whether or not the patient has already had a routine EEG in a recent time period, and whether or not that routine EEG may have been abnormal or not. But even if the patient did have a routine EEG that was abnormal, many times we would want to get more data to collect with a long-term EEG study. With more data to observe and to analyze, we're more likely to find abnormalities that we can act upon that may be particularly important for the patient's care. Additionally, many times when you get a routine EEG study, the study is only done when the patient is awake or may get drowsy. However, the brainwaves change when you are asleep compared to when you are awake and drowsy. And a long-term EEG study will be able to analyze all aspects of the patient's state of being while the patient is awake, drowsy, and asleep. And many times you can get much more information when you look at the patient as a whole in all aspects of being. Epilepsy is a very esoteric type of diagnoses and a very hard type of diagnoses to get to. It is also a networking disorder of the brain where patients present with a myriad of different signs and symptoms, where seizures are not just the only aspect that we're trying to look at. So while we get a lot of key information from our patient's history, our EEG studies do provide a lot of objective data that we potentially can act upon. When we do have a history that may suggest that the patient is having an epileptic-based problem, and our EEG studies do show evidence that there is objective evidence of cortical hyperexcitability, a lot of these patients will be prescribed an anti-epileptic medication in that standpoint once the EEG does show some consistency and some objective evidence to suggest that our history is initially correct, that the patient does have an epileptic-based disorder. That being said, there are 10% of all epileptic patients that can have totally normal EEGs. We do understand that the EEGs have their own limitations in that only about 2/3 of the brain is sampled from EEG monitoring, but deep areas in the brain that aren't necessarily seen by scalp EEG electrodes, that's where we rely on our clinical judgment. If a patient's history suggests that the presentation is that of an epileptic disorder, yet the EEG studies are totally normal, an EEG that is normal doesn't preclude a diagnosis of an epileptic disorder. And that's really why an epilepsy specialist, like an epileptologist, is most adept at diagnosing epilepsy in these particular cases when the EEGs are normal. So to answer the question, we don't necessarily always act on abnormalities on an EEG. We have to take into account every aspect of our patient's workup and really take into account our patient's history to really act on what we think we need to act on. On an EEG, we talk about non-specific abnormalities where someone may have focal slowing or generalized slowing on an EEG. Slowing of the brain waves are non-specific abnormalities on an EEG that either may indicate that the patient has some sort of problem involving a region of the brain or the whole brain itself. However, that problem can range anywhere from there being a structural abnormality to a patient having a toxic or metabolic problem. So slowing on an EEG just basically tells us that there's something non-specifically abnormal. And then based on the history, uh, we would then formulate a workup based on what our patient is telling us and how the patient is presenting. There are specific abnormalities on an EEG that really do often point out to an epileptic diagnosis. What we look for as epilepsy specialists are things that are called epileptic spike and slow wave discharges or epileptic sharp and slow wave discharges. These are specific abnormalities directly related to areas of the brain that are hyperexcitable, where a group of neurons are firing synchronously together, and that synchronous firing of neurons together shows up on an EEG as an epileptic spike wave, the graphical representation of a group of neurons within a network that are hyperexcitable. The other abnormalities that we see and why we often do continuous video EEG monitoring are if we actually capture seizures. A seizure on an EEG is a sudden rhythmic activity either in a portion of the brain, as in the focal epilepsies, or in the whole brain itself. Generalized epilepsies oftentimes have rhythmic discharges involving the whole brain itself. Knowing the EEG, knowing the way that the epileptic discharges are, knowing how the seizures present, it's really important for us as epilepsy specialists at the initial phases of diagnosing an epileptic condition to know whether or not our patient has a classification of generalized epilepsy or focal epilepsy, because the classification of the epileptic patient's seizures is key to proper management. You want to know if a patient has focal epilepsy and that there is a slew of different anti-epileptic medications available for that patient, whereas a patient with generalized epilepsy may be limited to only a certain set of anti-epileptic medications, whereas other anti-epileptic medications that are meant for the more focal epilepsies may worsen or potentially worsen the epileptic disorder if the patient is classified as a generalized epilepsy and is given a focal anti-epileptic medication. So our EEGs really do help guide us in terms of understanding the disease process and helps guide us in terms of proper management of our patient's condition because it helps allow us to choose the proper anti-epileptic medication.